Thank you for this invitation to the program committee. I was tasked with discussing progress in the management of lupus nephritis. These are my disclosures. The objectives for today's talk is discussing the therapy of lupus nephritis. And to begin with, I shall discuss the 2021 KDIGO guideline. Following this, I will discuss unmet needs with current therapies for lupus nephritis. And then we'll talk about novel targets and some recent clinical trials that are close to completion and those that are in progress, both phase 3 and phase 2. And then finally, using novel technologies, what could be the future paradigms for the diagnosis and treatment of lupus nephritis? As of 2021, there have been several drugs that are FDA approved for the treatment of lupus and lupus nephritis. So you can see from 1948 to 1955, there were only 3 drugs approved: aspirin, steroids, and hydroxychloroquine. And it took about 40 years to get the next drug approved, which was belimumab. And then finally, last year, 2 drugs have reached FDA approval: belimumab again for lupus nephritis and voclosporin. To note that most of the drugs that we prescribe are essentially off-label because they have not really been shown in pivotal clinical trials to be effective in lupus nephritis, although we are aware that they're effective. So the KDIGO guideline took about 4 to 5 years in the making, and it has finally appeared in print in Kidney International, and you can also obtain it from the KDIGO website, kdigo.org. So there are several steps discussed in the general management, but the most important from the point of view of a nephrologist that we should not forget the use of an antimalarial like hydroxychloroquine or equivalent. And of course, screening needs to be done for these patients who are on the drug for side effects, most notably retinal disease. And the first time one should screen this is at a minimum of 5 years, and then every year thereafter. For class 1 and class 2 lupus nephritis, so if they have some proteinuria with or without hematuria and they get a biopsy, if the level of proteinuria is low, in the absence of class 3, 4, or 5, the treatment is dictated by the presence of extrarenal manifestations. One exception is in patients who present with the nephrotic syndrome, and you see on the right panel, they have immunofluorescence positivity in the absence of light microscopy showing endocapillary lesions. One should suspect lupus podocytopathy. If you do have EM, you see this diffuse foot process effacement. But even in the absence of EM, if you have minimum endocapillary proliferation in the presence of nephrotic syndrome, this is lupus podocytopathy. And one treats these patients as you would with minimal change disease. And these patients might need maintenance therapy to prevent a relapse of podocytopathy in the future. When we come to induction therapy for class 3 and class 4, I'd like to compare KDIGO 2012 on the top panel with KDIGO 2021. You can see in 2012, there were 3 choices of cyclophosphamide: IV monthly, oral daily, and IV every 2 weeks. This was the NIH protocol, and this 500 Q2 weeks times 6 was the ELNT protocol. And then you were also able to use oral mycophenolate, and all these were given for a period of up to 6 months for the IV and PO cyclophosphamide, and 6 weeks, 6 doses for the ELNT protocol. In 2021, things changed a little bit. You can see that the dose of methylprednisolone is lower. It's 0.25 to 0.5 grams a day for 3 days. And then the maintenance can be somewhere between 0.5 and 0.6 compared to 0.5 to 1 gram bolus and 1 mg per kilo as maintenance. And then there are only 2 choices now that we think are appropriate. That's the intravenous cyclophosphamide ELNT versus the oral mycophenolate as before, 2 to 3 grams. So we don't really need to go into the higher doses of cyclophosphamide because it's been shown across a bunch of studies that the ELNT protocol is good enough with possibly lesser side effects. So a couple of points about induction therapy. So we discussed corticosteroids, mycophenolic acid, and cyclophosphamide. So there's really no difference between the two protocols in terms of mycophenolate versus cyclophosphamide. You can choose based on availability, cost, and patient adherence. But what is important is that the concept of adding calcineurin inhibitors is now new in the guideline. And this is based on the Chinese study that looked at tacrolimus with a level approximately of 5.5 of the trough level, added on to reduced dose MPAA, which stands for mycophenolic acid analogs. And these are patients whose kidney function is relatively intact and to be used for up to 24 months. And more recently, voclosporin, which is a cyclosporin analog, is now FDA approved, and I shall discuss some of the aspects of treatment. But again, we like to limit CNIs to patients with relatively intact kidney function. On the other side, the B lymphocyte targeting biologicals have now been FDA approved. So belimumab is now approved for patients as induction therapy added on to either MPAA or IV cyclophosphamide. And this is given as an IV or now a subcutaneous infusion. There is still a role for rituximab in refractory lupus nephritis, which we shall discuss a few slides down. So the field of induction therapy has changed with the addition of CNIs and B lymphocyte targeting biologics. So what can we do with patients who do not respond well to the induction therapy? The number one problem is going to be adherence. People may not take the medicines either of non-adherence or because of costs. So one way to make sure that the medicines are being taken is to check levels and checking the infusion registry to make sure that the cyclophosphamide has been given on time. We sometimes do a repeat biopsy to make sure we do not miss other lesions, or if the patient's fibrosis is too far advanced, leading to secondary FSGS, for example. And then one may switch to the alternate medication. So if you're on MPAA, you can switch to cyclophosphamide and vice versa if there's a suboptimal response. And then finally, add-on therapies. So a common practice is to add on tacrolimus or cyclosporin if mycophenolic acid has not worked, or you can add rituximab or other biological therapies. And lastly, one may also extend the course of IV pulse cyclophosphamide beyond the 6 doses that we have used in the ELNT trial. For maintenance therapy, the most important aspect, other than choice of drugs, is to reduce prednisone as far down as possible. And with the newer add-on therapies, it's been possible to actually discontinue it completely much earlier than what we used to do. So the first choice for maintenance is an MPAA, mycophenolic acid analog, and the doses are much lower for these drugs compared to induction therapy. And if there is a reason that you cannot use MPAA, azathioprine is acceptable. And if neither can be used, either a CNI or myzoribine, which is not available in many parts of the world, has also been accepted. For class 5 lupus nephritis, it's a little different. If the level of proteinuria is low, we just keep monitoring the patient for how much the proteinuria is running at, and if there's any complications like thrombosis and so on. But in general, conservative management with renin-angiotensin blockers are adequate. And the reason to use immunosuppressives is guided by extrarenal lupus. And please don't forget not to forget hydroxychloroquine in these patients. If you're nephrotic, in addition to hydroxychloroquine and RAS blockade, steroids in usually a less than 0.5 mg per kilo dosage with any of these other agents are permissible. NPAA, cyclophosphamide, CNIs, rituximab, and azathioprine. And of course, if any time the patient has worsening proteinuria on a conservative management, one can utilize these immunosuppressive combination therapies. So what is important is treatment response. A complete response is defined as a reduction in proteinuria less than 0.5 grams per gram. And this is important. We take a 24-hour urine, which you know is never optimally collected, but you do a protein to creatinine ratio in that sample. In addition to this proteinuria reduction, we look at stabilization or improvement in kidney function, plus minus 10% of baseline. A partial response is a 50% drop in proteinuria and to less than 3 grams in the same method that we had discussed in complete response. In addition to that, again, kidney function needs to be stable, and the time interval for both these endpoints is usually between 6 to 12 months, because many times you do not see an earlier response. And that is the reason why many of the older clinical trials actually failed to show a positive signal, because it was terminated, the endpoint was adjudicated too early. So 6 to 12 months is approximately when we begin to see these responses. And again, if there's no response in terms of complete or partial, the patient is deemed refractory. A relapse is treated very similarly to the original episode. So there are certain special situations in the treatment of lupus nephritis. So one possible coexisting diagnosis is thrombotic microangiopathy. So if you make a diagnosis of TMA clinically, the most important thing is to rule out ADAMTS13 associated TTP. So we draw the levels and we use something called a plasmic score or the French score to predict whether this patient could have TTP. And you can find this on any online calculator. So there's a high risk. We immediately start plasma exchange without any delay and give steroids while you're awaiting results of the ADAMTS13 test. If it's low, under 10%, we call this SLE associated TMA, TTP, and then continue the plasma exchange and steroids, and we add on typically rituximab to gain control of this disease. And once they reach hematological remission, you can stop the plasma exchange and continue the other immunosuppressives. If the ADAMTS13 is normal, but they have positive antiphospholipid antibodies, we call this APL or APS nephropathy. And here we need to anticoagulate with plasma exchange and with or without rituximab. If you're negative for both, we have to look for complement associated TMA. And then if available, it's eculizumab or FFP with or without plasma exchange is long-term therapy until they get better. And there are always other etiologies we need to look at as well, like you would in any patient with the TMA. In a patient who is considering pregnancy, one must avoid pregnancy while the disease is active and avoid all drugs that are teratogenic. And we need this to be patient to be in remission for at least 6 months before becoming pregnant. Hydroxychloroquine should be continued, and aspirin should be started low dose before 16 weeks of gestation. Glucocorticoids, hydroxychloroquine, azathioprine, and CNIs are all safe in pregnancy. In pediatric patients, the same protocol in terms of immunosuppression is employed, obviously with dose adjustment, and one needs to pay specific attention to growth and fertility issues in young people. And there is also attention needs to be paid to psychosocial factors in the treatment of these patients. As we know, a lack of remission in the bottom graph is associated with a poor prognosis in terms of end-stage kidney disease and death, whereas even partial remission and complete remissions are associated with a very good outcome. So one must try for at least partial remissions, if not complete remission, in these patients. So how are we doing with standard therapies? So as we know, the ARMS trial showed no difference between MMF and IV cyclophosphamide, but remember this was adjudicated at 6 months. And it is possible if you were to carry on the adjudication a little longer, you might see a better outcome in terms of patients responding. And likewise, if you look at the maintenance aspects of the ARMS trial, there is still a significant rate of relapse from between 20% for MMF and up to 40% for azathioprine. So these are some of the unmet needs with the current therapy. We need better improved remission rates. There is still a significant number of patients who do not respond to initial therapy. There is a significant number of people who relapse. And generally, although the endpoints have improved, there is a lack of any non-invasive biomarker for monitoring disease therapy. As we know, creatinine and proteinuria are not the most informative in terms of its correlation with the kidney biopsy. We need drugs that do not have side effects, if possible, and the costs are still extremely high, including for drugs like MMF and the cost of kidney biopsy and drug monitoring as well. So let's now discuss novel targets and certain recent clinical trials. To understand the pathogenesis of lupus on which therapy is based, think of these cells which are dying, either naturally or because of stress like ultraviolet radiation. So through apoptosis and through necrosis, you get release of circulating nucleic acid analogs or derivatives, right? And these are quite immunostimulatory. So for some reason, patients with lupus have a problem clearing this, and they're also very immunogenic to these particles. So it all begins at the dendritic cell, which takes up these nucleic antigens and presents it to the T cell via the MHC receptor, and in the presence of co-stimulatory molecules. The T cell then presents the same antigen to the B cell through the same series of receptors, activating the B cell. B cell needs the CD20 and CD22 surface proteins to be able to function. And it also needs to have BLyS, which is a B lymphocyte survival factor, which is typically secreted by other inflammatory cells, for it to differentiate into a plasma cell, form the autoantibodies, and then these will bind to immune complexes, which will then deposit in the kidney, leading to inflammation, and through a process of multiple cytokines being released locally, it will also involve complement. It causes inflammation and the disease we now know as lupus nephritis. So in terms of intermediate events, what we can see right now is that how do we treat such patients? Looking at this pathogenic model, there is no treatment for the early pathogenic events, okay, but there's a lot of treatments for these intermediate events. So these drugs like cyclophosphamide and antimetabolites are all aimed towards the B and T cell response to these antigens, and they're quite effective, as we know. But what else can we do in these patients? So if you look at the role of add-on therapies, so this is a study from China that we had mentioned. It added tacrolimus to MMF and steroids and compared it to cyclophosphamide and steroids. And you can see that during induction, the probability of overall response was much higher in the multi-targeted group compared to intravenous cyclophosphamide. But over time, there was no difference in the relapse rates with either. So yes, clearly there's a much more robust complete remission and partial remission rates with 3 drugs versus 2 or versus cyclophosphamide. Long term, it doesn't make a big difference. So now we look at some novel therapies. So voclosporin is just one side chain that is being altered on cyclosporin, and by doing so, it changes the pharmacokinetics very dramatically in such that it's a flat PK profile. The levels do not fluctuate like you see with cyclosporin. And consequently, there's no need to monitor levels, and you can get by with just a standard dose in all patients. So the study was Aurora 1, and it looked at complete renal responses at weeks 52 and 24, comparing placebo to voclosporin added on to MMF and tapering of steroids. And what is important in this study is that there was a forced steroid taper if possible. The idea was to limit steroid exposure with an add-on therapy. And it turned out that voclosporin was associated with an approximate doubling of complete renal response rates at 1 year, a little less at 24 weeks, but again, significantly different, with no change in the adverse event profile. The next class of drugs are targeting the B cell and the B cell to plasma cell differentiation. And you can see molecules that target CD20, rituximab, ocrelizumab, and then CD22, ifratuzumab. They're all negative trials, unfortunately. And other drugs that target the co-stimulatory molecules like abatacept also was negative. And then finally, there's a group of drugs which targets the lymphocyte survival factors. It's also known as BLIS or BAF. And the other group of survival factors are called TACI. So when you look at why rituximab failed, okay, so this was a post hoc analysis of the LUNA trial, which looked at rituximab added on to MMF and prednisolone. So why was it negative? If you do a subset analysis, you see that in 78% of patients who had complete depletion of B cells, defined as 0 cells, the response rate was much higher, 47%, compared to those patients who had 1 or more cells after giving rituximab. And there, the rate is only 13%. So there's a clear difference in the response rates when you achieve complete B cell depletion. So perhaps rituximab was not as effective as you'd like in depleting B cells in this trial. So we now look at the next generation of anti-CD20 antibodies. And here we look at obinutuzumab compared to Ritux and ofatumumab. There's a much stronger destruction of B cells using direct cell death or antibody-dependent cellular cytotoxicity mechanism. So patients who receive OB have a much more profound depletion of B cells. And in fact, the trial, which is a phase 2 nobility trial, was released last year. And here they added OB on top of MMF or MPA, which is mycophenolic acid, and steroids. And then this trial also was associated with a targeted reduction of prednisolone dose. If you see the renal responses at varying time points, week 52, 76, and 104, in the OB group in blue, you can see a combined partial and complete remission rate is much higher than placebo across the way. And again, there was not a big difference in the side effect profile. The other group of B cell therapies is the lymphocyte survival factors. So if you look at this factors, APRIL and BAF or BLIS, so there are several types of these factors, and they all basically attach to these receptors on B cells, plasmablasts, and plasma cells. So in the absence of these survival factors, if the lymphocyte is stimulated, these cells, the plasma cells and the B cells, undergo involution and apoptosis. So this is one way to augment the response to the B cell modification. So two sets of drugs, atacicept and blisibimod and tabalumumab, which acts on different parts of this axis, were not effective in randomized trials, but belimumab was effective, which works essentially against soluble BAF. So this was the BLISS-LN study, which looked at belimumab versus placebo in patients with class 3 to 5 lupus nephritis with relatively intact kidney function. And you can see right here, both partial and complete responses were much higher in the group that received belimumab. And as a result of this trial, this drug is now available, FDA approved, for use in lupus nephritis. How about rituximab? Has it gone away completely? Clearly, there's a role. It's not gone away completely. We saw that some patients do respond if they can completely deplete B cells. And I think this is a very important aspect of treating such patients, is to monitor B cell responses. But you can see in a collection of patients who had not responded to standard therapy, there was an incremental response with the addition of rituximab, up to 60%. The other reason to use rituximab is to avoid steroids. And this is the Rituxi-Loop and Rituxi-Rescue trial. These are open-label, non-controlled studies done by the Hammersmith group in London. And here they use rituximab, 2 doses, with a single pulse course of methylprednisolone with no subsequent steroids, with MMF on board. And they looked at follow-up. So you can see right here that in both these studies, the response rates was over 70% at 24 months. So the idea is that you can get by without steroids if you use combination therapy. But this is not tested in a controlled trial. So it's still not, it is an option, but it's not fully endorsed by the KDIGO. The other place where you might need to use sequential therapies is refractory patients. So these are patients who were refractory to conventional therapy. They received rituximab initially and then randomized to IV belimumab and then IV versus IV placebo. So over a year, 3 flares in the belimumab group versus 10 in the placebo group. So clear difference needs to be validated, but this is another thing we can do in our patients who are refractory, is not just give rituximab, but give Ritux followed by belimumab if it's available. The other area that's in the intermediate events is the role of interferon. It's very, very important in lupus, and there's a blocker of the interferon effect called anifrolumab. So this was the TULIP-2 study, not in lupus nephritis, but in lupus, which showed a clear improvement in the response rates of this composite called BICLA, and also a reduction in the flare rate. Again, this is now approved based on this trial for use in systemic lupus, but not yet in lupus nephritis. So you can see there's a whole host of ongoing clinical trials, and you can see the name of the drug, anifrolumab, is TULIP-LN1, same antibody to interferon alpha. We are looking at a phase 3 pivotal trial of OB, which is the anti-CD20 antibody. We saw the phase 2. Secukinumab is an antibody to IL-17. Guselkumab is IL-23. So the top 3 are pivotal trials, and the rest are all type phase 2s. So we have a Bruton tyrosine kinase inhibitor. We have an anti-CD40, which is a co-stimulatory molecule. We have a tyrosine kinase 2, and we have an anti-CD6 antibody called itolizumab. And this drug, the last drug, was actually developed by a company in India. And it's a multinational study that's going on. So we have a lot of ways to treat lupus and lupus nephritis. The question is, with the availability of so many drugs, can we target a drug for a specific profile of a given patient? So to give you an example, of the 10 highest grossing drugs in the US, you can see the drugs we commonly use, a PPI, and drugs for schizophrenia, arthritis, rheumatoid arthritis. So all these, the blue are the patients in whom the drug actually works and the patients respond, and the reds are the patients in whom the drug doesn't work. So despite so many people receiving the drug, a small proportion of patients actually see benefit with all these drugs. And that includes a statin, for example. So how can we narrow the efficacy of a drug based on a patient's profile? We need to understand what the profile is first. So yes, race and socioeconomics were the earliest factors that we looked at. And you can see very clearly that patients who are Caucasian or white do much better than non-Caucasians. And there's a steep difference in the outcomes when low poverty is compared to high poverty in terms of outcome. But what is new are transcriptomics. So this is a chip that reads interferon-related genes, whether they go up or down. And this is, it adds up all these in a composite called the interferon signature. So when you take a normal patient in the dotted line, they have a low interferon signature. And patients with lupus have a higher interferon signature. But even within the lupus population, patients with mild SLE have a much lower interferon than those with moderate to severe SLE. So you can kind of look at the readout on these chips and you can figure out lupus activity based on these chips. In fact, in the first negative study looking at nephritis, it is only in the high interferon signature group that treated patients managed to get a response compared to the low group. So it makes sense that if your interferon signature is not very high, giving an anti-interferon drug may not be effective. In fact, in clinical criteria as well, this difference stood out in terms of low versus high. How about cyclophosphamide, a drug we commonly use? The cyclophosphamide is broken down, actually bioactivated to an active form using the CYP cytochrome system. So if you have any polymorphism in the cytochrome system, it might make a difference in the level of activation. So this whole field is called pharmacogenomics. And in fact, in one study, if you have a loss of function allele, so if you have 1 versus 2, your rate of bioactivation is much lower in those people who have a 1 or a 2 loss of function allele. So these patients may not respond very well to cyclophosphamide. So the other way you can look at precision medicine is to take a sample of blood and run a transcriptional profile. So what mRNA is upregulated and which pathway is affected. So you take healthy versus lupus patients, and we saw interferon's a big predictor of who has lupus. But in terms of activity, it's not just interferon, but you can look at the signature that plasmablasts produce. And patients who are active generally have very high plasmablast signatures reflecting antibody production. And in terms of nephritis, which is inflammatory, neutrophils surprisingly give a very strong signal in separating nephritis versus non-nephritic patients with lupus based on kidney biopsies and clinical criteria. So you can see in a given patient, you can look at combinations of these signatures and see which pathway is upregulated. And each group may have a specific pathway that is upregulated, and that might be conducive to designing a set of therapies for a given patient and also monitoring them long-term to see what the effects of these therapies are on these signatures. The other way you can look at lupus and lupus nephritis is to look at non-invasive markers. So you take a skin biopsy and take a keratinocyte and do what's called a single cell transcriptomics. So you take one cell that you think is important, and in that one cell or set of cells, you can see what is up and down regulated. So you can see right here compared to healthy, there's clearly a signal in patients who respond and do not respond to therapy. So non-responders have an interferon score that's really high compared to responders who actually resemble healthy patients in the skin biopsies, mind you. And these we're looking at kidney responses. And in the kidney, very interestingly, the upregulation of collagen genes has an almost perfect AUC in predicting non-response and fibrosis. So these are all concepts that are being explored in trying to bring what's called precision medicine to the table, in defining which patient might be at risk of progression, which patients would respond to a particular kind of therapy, and so on. So to conclude, we do have a number of drugs now. The backbone is still cytotoxics or antimetabolites on top of steroids. But there's this very significant adverse event profile, and many patients cannot achieve a complete response or a cure, and there's also a risk of relapse despite complete remission. There's been an explosion of targeted therapies. Belimumab is FDA approved for lupus nephritis. Obinutuzumab has shown a very strong signal and is being investigated, as are other therapies. We are looking at multi-targeted therapies, although voclosporin is available in the States. It may not be available elsewhere, but clearly CNIs have a role in what's called multi-targeted therapies of such patients. And we'll need to be on the lookout for precision medicine approaches to treat lupus nephritis. Thank you very much for your attention, and I'll be open for questions.